So today we are going to see the diseases of the respiratory system. Yesterday we have seen what are the respiratory anatomy, respiratory physiologies, then mechanical ventilators, respiratory pharmacologies, and so on. So the remaining portion, the assessment of the patients with respiratory disorder. I have already said the assessment portion is important. We have to focus on this assessment system as well. Okay. So here comes the diseases of the respiratory system and its assessment of the patient. So inhalation and exhalation. So the diaphragm moves down when the uh, uh, when you inhale, and the diaphragm moves up in case you when you exhale. Okay. So the respiratory pathway disorders. There are some respiratory pathway disorders like sleep apnea will be the airway obstruction and the tracheostomy. Okay. In here, the two major things which you have to focus is on the airway obstruction as well as the tracheostomy. So in the tracheostomy, what you have to check the mainly the suction. So we have yesterday explained what a suction is, how we have to do the suction in case of tracheostomy. Okay. Second is the changing cleaning of the airway systems that when we have given to the tracheostomy. And second is the airway obstruction. If there is any airway obstruction, so if there is any mechanical obstruction for the pediatrics, we'll do the Heimlich maneuver. Okay, you know that Heimlich maneuver, right? Now, the collection of patients' data. How will you collect the patient's data? First, in the respiratory system, the main thing is allergies. You have to check for the allergies. Okay. Yesterday, when we were dealing with the medicine, we have said that histamines, like in the respiratory system, the histamines play a vital role. The interleukins as well as tumor necrotizing factors, all these comes into play. So all these mediates the allergies. So you have to check for the medical histories of the in some conditions in some conditions these allergy might be because of any sort of pollen grains. It may be due to dust, or it may be because of any things which may act as an antigen that causes an allergy to the patient. In those allergy, the first foremost presenting complaints will be of the respiratory system. Mainly dyspnea will be the then family history. If the family is having any history of bronchial asthma, yes, do the children may carry that. So the history of bronchial asthma, then risk factors associated. It may be an occupational disease like asbestosis, silicosis, vaginosis, byssinosis. All these things will be a risk factor. The persons who are working in such kind of area as an occupational disease. Then the risk factors will be immunocompromised patients, the patients on chemotherapeutic medications, the patients on any other suppressive medication, patients who have undergone kidney transplantations and so on are will be in the risk factors. Mm. Social histories like cultures, like the smoking, whether the smoking will be in the culture or uh, as a history of the personal habits. Then medications. In some conditions, these medications will also erupt the respiratory areas. Okay, the nutritional status. What will be the nutritional status? How emaciated is the patient is? How the protein status of the patient? Like you can see it in TB, tuberculosis. Okay, nutrition. There will be weight loss or not. And travel areas. A residential areas. If the patient is residing near to any factory, yeah, those are the travel histories. Now, first one is the obstructive lung diseases. So the main characteristics and the common characteristics, it is common. The obstructive lung diseases is common, and it causes a recurrent blockage of these airways. Okay, the obstructive lung diseases is a chronic condition. Okay, it's a chronic condition and it causes a recurrent blockage of the airways. The blockage of the airways can be because of the mucus plugs. Okay. Any mucus plugs may cause these any mucus plugs may cause such kind of obstructions, or it may be because of the fluid which is filled in the respiratory system. Usually, it is happening because of the mucus plugs, and it limits the airflow through the airways. Okay, so the chronic obstructive lung diseases, it may it may block the airways because of its mucus plugs which is present in the respiratory tract. Okay, see, when there is an obstruction in the respiratory tract, it leads to what? Clubbing of fingers. Okay, the clubbing of fingers will be the main thing, and there will be mediastinal shift. Your sternum may be shifted to one side, left or right side, if there is a right ventricular hypertrophy. Okay, and next is the risk for sleep apnea. What are the risks for sleep apnea? So we are doing the assessment portion. Okay, we are doing the assessment portion of the respiratory system. So in case of sleep apnea, there will be overweight may be a reason. Obesity may lead to sleep apnea. High blood pressure patients, decreased airway size, so congestion of the respiratory system, allergies in the respiratory system, anatomical abnormalities. Okay. See, yesterday we have seen this sounds, right? What is crackle? What is wheeze? What is stridor? What is frictional drum? Okay, stridor, I think I have missed, but it is just an airway obstruction which is caused by a high pitched sound. Okay, yeah. The clinical manifestations of airway obstruction, there will be stridor. Simply, you can say it will be wheeze or an bronchi. Basically, wheeze will be the if there is an airway obstruction, a narrowing of the airway, it may lead to the wheeze. Okay, and the patient will be unable to speak because of the respiratory grunting. Labored will be the and the patient may use accessory muscles. Okay, see, normally this breathing is a passive process. Like, even inspiration will be an active process, but the expiration is a passive process, and we won't feel that much pressure when we are respiring. But in case of these airway obstructions, the breathing itself will be labored. The patient have to take the respiration very often, and it will be very difficult for the patient. Labored breathing will be the and in cases of labored breathing, it also leads to nasal flaring. You can see nose the nose will be enlarging and slurring, which is known as a nasal flaring. And air hunger will be hunger, right? So air hunger, craving for air will be there. And in severe cases, in severe obstructions, you can see cyanosis as well. Okay. Next, what are the laboratory tests or the diagnostic procedures that we'll do? First one is tuberculin skin test. We'll do the skin test for the tuberculosis. Why? The respiratory system might be always associated with the tuberculosis TB. Okay. So, if there is a weight loss, if there is anything related with the cough, sputum production for more than 2 weeks, and there is an associated weight loss, we'll suspect tuberculosis. For that, we have to understand the tuberculin. We have to do the tuberculin skin test. See, when we are doing the sputum analysis, we can only identify whether the TB is there in the lungs or not. To understand whether the TB is whether present in the extrapulmonary region, which might be in the brain, which might be in the blood, or in any lymph nodes, or in stomach, or any interstitial organs, we have to do the tuberculin skin test. Okay, now chest X-ray, we have to take the chest x-rays. So there will in pneumonias, there will be haziness of chest x-rays. You can see consolidations in tuberculosis or in the obstructions. Air won't be passed to that area, thus leading to consolidations in the lung field. Okay, or it may be because of a cancerous growth, any tumors in the lungs, which can be seen as a cone-shaped areas in the lungs. Okay. Next is acid fast bacillus smear that we have already said, and the sputum cultures. We have to check whether there is any other associated bacteria or not. Okay, apart from this TB. Okay, so lobes of the lungs, we have there are two lobes in the right lung and one lobe in the left lung. Okay. Since there are two lobes in the right lung is divided into three portions. Since there are one lobe in the left lung is divided into two portions. Okay. We have in the right lung, we have the horizontal fissure, and in the right lung, we have the horizontal fissure and the oblique fissure. Okay. Horizontal fissure and the oblique fissure. And in the left lung, we have the just an oblique fissure. Okay, that is dividing the lungs into parts. Yeah, clear. So the anatomy of the pulmonary system, which we have already explained yesterday, like the see this one, clinical manifestation of cardiogenic or non-cardiogenic pulmonary edema. Okay, so in case of cardiogenic or non-cardiogenic pulmonary edema, see, usually this pulmonary edema may be associated. The pulmonary edema may be associated with cardiogenic diseases, or it may be simply because of it is affecting the respiratory system. Okay, so let me discuss the condition here also. What pulmonary edema? The pulmonary edema is nothing but a rapid accumulation of fluid in the lungs, okay, or on the lung tissues. So pulmonary edema is a rapid accumulation in the fluid in the lung tissues and in the alveolar spaces. Okay, it may be due to acute heart failure also. Okay. Pulmonary edema can also be associated with heart failure. In that condition, we can say that it is cardiogenic pulmonary edema. Okay. So cardiogenic pulmonary edema and non-cardiogenic pulmonary edema. What is pulmonary edema? It is an acute rapid accumulation of the fluid in the lung tissues and in the alveolar spaces. So the lungs and the alveolar spaces will be filled by the fluid. See, understand this thing. If a patient, you are giving patient 1 pint NS or 2 pint RL, something like that. You're giving fluid to the patient. So it should pick up the blood. It should pick up the BP. Okay. Or when the it should pick up the BP, or else it have to be excreted in the urine. And if you have given 1 pint fluid to the patient, the second pint fluid to the patient, and the patient is not having an urge to urinate, there is no urine coming, then you have to suspect where is this fluid going. Some conditions, the fluid which we have given 1 liter of fluid, so at least we want 800 or 750 mLs of urine output, right? So intake as well as the output should be normal. So there is only 1 liter of intake, there is no output. So you have to check where is the culprit, what is the culprit, where you have to check it. One thing, it may be because of internal hemorrhage might be there. Okay, you may not expect that internal hemorrhage. So you have to work for the internal hemorrhage. Second one is urinary retention will be there. So the bladder will be full. It might be because of the see, we have renal causes and post-renal causes. Like a post-renal cause of the prostate gland enlargement. So in case of prostate gland enlargement, there will be urinary retention, but and there won't be any urine output. So you have to check for the bladder, whether it is there in the bladder, or it may be an interstitial space shift, fluid shift, which you can assess. We can check by the edema status of the legs. All the fluid will be present in both the legs of the patient. So bilateral pedal edema will be there, or you have to check for the lungs. In the lungs, this fluid may be accumulated as pulmonary edema. Okay, rapid accumulation of fluid in the tissues might be there. So usually, if we are giving the fluid to the patient, you have to consult the edema status. You have to consult the respiratory status, cerebral status, urinary status, and abdominal areas. Okay, whether there is an internal bleeding or not. So you have to check for the lungs for the pulmonary edema. Okay. I know. Crepitations will be there. Okay. In case of pulmonary edema, you can hear creps. No, as a symptom, there will be agitation for the patient. The patient will be agitated. There will be confusion. Then there will be evidence of the cardiac problems will be we can usually in pulmonary edema there will be any associated cardiac disease also. And kindly underline that point. There will be pink frothy sputum in pulmonary edema. I have explained it yesterday. It's a pink frothy sputum in pulmonary edema. Okay. And the main signs and symptoms, kindly write it down. The main signs and symptoms of pulmonary edema. There will be shortness of breath. There will be paroxysmal nocturnal dyspnea. And I believe we have explained this paroxysmal nocturnal dyspnea also when we are dealing with the cardiovascular system. So shortness of breath will be the paroxysmal nocturnal dyspnea will be the wheezing. Then orthopnea, crackles will be the when we are auscultating the lungs. Pallor, skin will be pale in color. Pallor, skin will be cold and clammy. Mm. And anxiety will be there. So what is the treatment? Simply in case of pulmonary edema, in any respiratory issues, okay, in any respiratory issues, you have to start the oxygen. Clear? The oxygen you have to start. Then we have to give the cardiac drugs. If there is a cardiac involvement, you have to go for the cardiac medicine. Next, morphine. If there is a pain, you have to go for morphine. Then the main thing is you have to hemodynamically stabilize the patient. Okay, you have to hemodynamically stabilize the patient. How will you hemodynamically stabilize the patient? You have to stabilize the respiratory system. You have to check for the ABG, whether the oxygen saturation is normal in the lungs or not, or what. If there is a cardiac involvement, you have to go for the cardiac involvement. Serial ECG must be there. And always you have to keep ready patient for intubation. In acute pulmonary edema, you might be needing an intubation status for the patient. Okay, so the tracheostomy, that's what I have said. In case of any an emergencies, you have to do the intubation. If oral intubation is not possible, tracheostomy intubation should be done. So this is the area where you are doing the tracheostomy. Just no, sleep apnea. Just understand that sleep apnea means when a patient stops breathing for more than 10 seconds. Okay. Or which is more than 20 to 30 times in an hour, then you can call it as sleep apnea. Okay. If a patient is not respiring, not breathing for more than 10 seconds, within more than 10 seconds. And what is the duration? In an hour, if it is more than 20 to 30 seconds, then it is known as sleep apnea. And what is the management for sleep apnea? We'll keep the patient on BiPAP. What is the use of what is the use of BiPAP? It covers the mouth and your nose so that it delivers the positive airway pressure to the patient. It is the mechanical ventilator. It's a mode of mechanical ventilator. It's a non-invasive thing. We can keep it in the house itself. Usually, such kind of patients will be having. They'll keep this in the mouth, in the face and sleep. Okay, and there are the types. We have central sleep apnea, obstructive sleep apnea, and mixed sleep apnea. Okay, in the central sleep apnea, what happens? So the culprit will be the brain. So the brain fails to send signal to the breathing muscles. Okay, so usually it is very uncommon. So the brain muscles, but the brain fails to send the signals to the breathing muscles to initiate respiration. So that is the main reason for the central sleep apnea. The next one is obstructive sleep apnea. So sleep apnea, what happens in that there will be a physical obstruction from the tissues in the upper airway so that the initiation of the respiration or the inhalation is stopped. Third one is combined mixed sleep apnea. It will be because of two things. Okay, and you can hear some additional breath sounds like stride. I have already explained what is stride is, right? Then pleural frictional rip can also be heard in that condition. And next condition is pneumonia. Okay. So what is pneumonia? Pneumonia is the inflammation of the lung that is causing emphysema or pleural effusion. So pneumonia means it's an inflammatory condition. Okay, lungs inflammatory condition, that is pneumonia. In this pneumonia, it may go for emphysema or pleural effusion. Okay, in pneumonia, it may leads to emphysema or pleural effusion. It may leads to, okay. It is not mandatory that all in all cases of pneumonia it should there should be emphysema or pleural effusion. Guys, what is the difference between emphysema and empyema? Emphysema is an air condition, whereas the empyema is nothing but pus will be there. Okay, that is the difference between emphysema and empyema. What is pneumonia? It's an inflammatory condition of the lungs. Now, there are some conditions. There are some classifications of pneumonia also. First one is community acquired pneumonia. From from your surroundings, you are acquiring the pneumonia. Community acquired pneumonia, the streptococcal pneumonia, Haemophilus influenza, chlamydia. All these things can cause pneumonia in the lungs. Usually, the main causative organism of pneumonia is Streptococcus pneumonia, or it may be a pneumococcal pneumonia. Okay, but in case of community acquired pneumonia, it may be causative organism might be Streptococcus pneumonia, Haemophilus influenza, or chlamydia. So that is the first classification of pneumonia. It may be on the basis of it is being getting. So first one is community acquired pneumonia. Second one is hospital acquired pneumonia. From the hospital, it may be a case of hospital acquired infection, hospital acquired pneumonia, right? Hi. So in the hospital, the main organisms are Staphylococcus aureus, okay, which is causing the pneumonia. Staphylococcus aureus will be a organism. Then you can have Pseudomonas aeruginosa. Okay, in the hospital you can have Pseudomonas aeruginosa. Then Klebsiella may be a reason. Okay, Klebsiella, the same thing which is causing the urinary tract infection. Klebsiella may cause pneumonia. Then streptococcal pneumonia, same. Then Haemophilus influenza. And in the kindly underline this MRSA, methicillin resistant Staphylococcus aureus, may cause the hospital-acquired pneumonia when the patient is admitted in the hospital. Okay, as a part of cross infection. So MRSA can be occurred through hospital-acquired conditions. Third one is aspiration pneumonia. So, which are the condition that causes aspiration pneumonia? First thing, the patient with tracheostomy, you can have an aspiration pneumonia. Second one, patient with Ryle's tube feeding. Okay. Then the patient who is bedridden for longer time, aspiration pneumonia will be there. Okay. And the fourth condition is AIDS, pneumonia. The main causative organism of pneumonia in AIDS is aspergillosis because it is an opportunistic infection. Then TB is a condition. Okay. Fifth one is SARS, sudden acute respiratory syndrome. SARS, SARS, sudden acute respiratory syndrome. See, in all these conditions, breathing difficulty is the prevailing complication. Okay, so when the patient is having severe breathing difficulty, first thing first, what will we do is that we just stabilize the patient. The respiratory act will be increase, you will be hearing wheeze, crepitations, crackles, and so on in your lungs. So what you have to do, just stabilize that. For stabilization, we'll give hydrocot for the patient, derafilin for the patient. If the heart rate is increased, we won't give the derafilin. Okay, we'll only go for the hydrocot. So when the hydrocot, it is a steroid like corticosteroid. So when you give this corticosteroid hydrocortisone to the patient, what happens? The inflammatory mediators like histamines will be shut down so that the severe breathing problems will decrease. Then we'll continuously take the nebulization inhalation. So when the inhalers, nebulization inhalers are taken, it will compromise with the respiratory patterns. Okay, so that is the management of pneumonia. And what is the treatment for the pneumonia? Medical treatment is simply we'll go with the conservative managements like hydrocodone, derafilin, and so on, and we'll go with the antibiotics. Okay, augmentin is a drug of choice, or you can go for cephalosporin groups like ceftriaxone, cefotaxime, or you can go for salbutamol. This those stuff. Okay, And usually, in case of hospital acquired pneumonia, higher dose of antibiotics are the drug of choice. We can go for pipirazine. Pipirazine is the drug of choice. Okay. So, explain what is the clinical manifestations of pneumonia that we have already said. There will be fever, chills will be the respiratory. Obviously, you can correlate when what happens when there is pneumonia. There will be respiratory rate increase in the respiratory rate will be the sputum. Your sputum will be rusty. So you can have a rusty sputum over the then what crackles will be the then what X-ray abnormalities as we know. There will be X-ray abnormalities, chest discomfort, cough. See them when we are using the muscles, there will be muscle fatigue. Okay. Now inspiration and expiration. So uh, just leave this. No, the lower respiratory disorders, lower airway disorders, inflammation and infections of the lungs. So see, the respiratory system, to study the respiratory system, it is very easy and useful. It is very easy because all the respiratory systems, the main complications or the main clinical features will be the respiratory distress. Okay, there will be a respiratory distress, breathing difficulty will be the nasal flurring will be the your chest will be having wheeze, stridor, and so on. So, all itis conditions may there will be the so bronchitis and all those things which indicates that there is an infection to the lungs. So when there is an infection to the lung, what you have to do, you have to just give the antibiotics. Okay. Then tuberculosis, we have explained tuberculosis, what are the treatments for the tuberculosis in the yesterday's pharmacology class. Okay, so there is no point in explain it again and again. Now, community acquired pneumonia, we have explained this community acquired pneumonia. Okay. So this is the tracheostomy, and you know all these things. Now, this is the exam point of view. Okay, abnormal breathing patterns, chain stroke respiration. I have explained it how the chain stroke respiration is affecting, right? How the chain stroke respiration affect. There is an irregular patterns of breath followed by a period of apnea. Then again, an irregular pattern happens of respiration, which is a deep penetrating respiration followed by a phase of apnea. Okay, so the causes may be a brain pathology will be there if there is a brain stem herniation, increased ICP. So that is a causative conditions in case of if it is affecting in the your CNS. If the CNS is the problem maker, then these things happen. Or in other conditions, if the respiratory system itself is a problem maker, then also in the chain stroke respiration, the respiratory patterns will be the problematic condition. If the like in case of pulmonary edema, then severe core pulmonales. Then in cases of uh, what severe pneumonia, it may all leads to chain stroke respiration. Okay, next Kussmaul's respiration. So we have said it's a labored and rapid breathing. Okay, mainly Kussmaul's respiration, also Kussmaul's breathing. Diabetic ketoacidosis is the main cause. Kindly mark it as important. In Kussmaul's respiration or Kussmaul's breathing, diabetic ketoacidosis is it's a culprit, it's the causative substance for the Kussmaul's respiration. And moreover, in the diabetic ketoacidosis, you can have a fruity smell. Okay, fruity smell will be the then metabolic acidosis and the renal failures will be the cause. And laryngectomy, you know what is laryngectomy and how it is being done for the temporary as well as the permanent conditions. Now, next condition is the lung abscess. What is lung? What is lung abscess? So it's the abscess, just the abscess inside the lung tissue. Okay, so there will be this cough and the sputum will be foul smelling. Okay, If you're having an abscess in your finger, if you're having an abscess in your lung, in your leg, you can see that the pus will be of foul smelling because the bacterial growth will be it may produce a foul smelling, or the odor will be foul smelling. Likewise, if in case of abscess, if it is a lung abscess, the cough or the sputum will be foul smelling. Usually, the sputum will be foul smelling. The bad breath will be from the patient if there is a lung abscess. And in another condition, there is a bad breath that is in oral cancers. Okay, if there is an oral cancer patient inside a ward, we won't be able to enter into that ward itself because due to that oral cancer, the entire ward will be filled with these bad breath. Okay, no, pleural chest pain. The chest pain will be the tachycardia. Then when we are percussing over the area, dullness will be there. So when we percuss on the lungs, see when we percuss on the lung field, we must get an a resonance sound. Okay. So if there is a lung abscess, we can hear dullness and the oxygen saturation may be decreased. Now, what are the care that you have to simply oxygenation? Oxygenation is the main area that you have to check for. So next is core pulmonale. Next disease condition is core pulmonale. So what do you mean by core pulmonale? So it's an acute result of pulmonary embolism. Okay, core pulmonale means it's a result of pulmonary embolism or injury to the ventilator disorders due to acute respiratory distress syndrome. Okay. The chronic core pulmonale is mainly caused by the COPD. Clear. So the respiratory perfusion changes. Just understand these points for your prometric exam. Okay. There will be a respiratory perfusion changes, and it also affects the hemoglobin level. Ventilation perfusion mismatch. That is the main point you have to check. Ventilator perfusion mismatch will be there. So the four types of pulmonary embolism which is associated with this core pulmonary, that is, there will be occlusion in the pulmonary circulation. So it may be because the pulmonary circulation. What is pulmonary circulation? From your right ventricle to the lungs. That is a pulmonary circulation and back to your heart, to your left atrium. That circulation is known as pulmonary circulation. So in that pulmonary circulation, there will be an occlusion. What are the causes for this occlusion? Any air embolism may be the reason. An amniotic embolism may be a reason. Okay, so all these conditions causes pulmonary occlusion of these arteries. Then infraction of the portion of your lungs, lung infraction. So as this heart infraction or the MI happens, myocardial infarctions, in same condition, lung tissues can also be infarcted because of decreased oxygen supply. And an emboli can happen. So you know what is emboli, right? It may be a blood clot, it may be an air emboli, it may be an amniotic emboli, anything. So what is the difference between thrombus and an emboli? Thrombus is a sedentary clot, whereas the emboli is a traveling clot. Okay. So this the last one. See, multiple pulmonary embolis can be uh, uh, a condition. This atrial flutters and atrial fibrillation. It causes emboli. Okay. Atrial flutters and atrial fibrillation causes emboli. So it can be an associated factor or the after effect of an flutter or a fibrillation of atrial conditions. So in what will we do in case of lung abscess? We'll take the CT. That is the best thing to take the CT, and we can go for thoracosynthesis. What is thoracosynthesis? And now we'll explain the procedure. What is thoracosynthesis? We'll keep the patient to sit on a stool, usually a stool, and allow him to bend towards the study table. So that is the position how we'll be doing the thoracosynthesis, right? Then after we'll be having guided USD guided thoracosynthesis to identify the correct area. Okay. But uh, uh, we'll be guiding. Uh, uh, it will be USG guided thoracentesis, what we are doing. And if that is not possible, we'll just percuss the areas and we can identify the dulls and proper dull sounds. Then that area is cleaned. The skin is prepared, like how we are preparing it for the surgery. We just scrub it with betadine, they scrub it with iodide, the iodine, which means the betadine. Then we'll scrub again with the spirit, and we'll apply a whole towel and we'll aspirate the fluid from the thoracentesis. Thoracentesis means we'll make an opening towards your lungs, basically in the visceral and the parietal layer, and we'll aspirate the excessive fluid which is present in the. So there are two types of thoracentesis. At thoracentesis, which we are doing for the diagnostic procedure and for the aspirative procedure. For the diagnostic procedure, we'll just take 10 to 20 ml of fluid. For the aspiration procedure, we can take up to 1.5 liters from the thoracic cavity. So when the 1.5 liters, uh, in some conditions up to 2 it can be go. Guys, any doubt? Whose mic is open? If you're having any doubt, kindly ask. Any doubt? Okay, so that is the procedure. We'll. Yeah, Rajeshwari, what? Do you have any doubt?
No, sir.
So that is thoracentesis. So the for the diagnostic procedure, we'll take the what? We'll take the 10 to 20 ml of fluid from the lungs, and we'll do the test for that. So culture will be done to identify whether there is any bacterial growth. Then we'll do the sugar analysis of that. TC, of this, these things will be done in the fluid. Okay. Then it's a bronchoscopy. We'll do bronchial wash or the bronchoscopy procedure. So what is bronchoscopy? We'll insert a catheter or a scopy directly into your bronchus, and a wash is given. Then we'll collect that wash and examine for the cells for any growth of organisms and so on. Or you can easily visualize this area whether there is any abscess present or not. Okay. Next is transtracheal aspiration via suction. So the sputum is collected from a catheter is passed, and the sputum is directly collected from the trachea. So what will be doing when we take the sputum analysis for the sample for sputum analysis? We'll ask the patient to clean the mouth thoroughly, and then we'll ask the patient to cough and take the sputum out through the mouth. So what happens is that when the patient is taking the sputum through the mouth, any bacteria which is only present in the mouth can also be present in the sputum when the patient is collecting like that. So in order to be very specific, more vigilant, we'll take the transtracheal aspiration. And that is one reason to have an proper identification. Second thing is if the patient is in coma stage, if the patient is in ventilator, if the patient is not able to cough and take the sputum, in those conditions, we'll do that. It may be that muscular dystrophy will be the lateral sclerosis will be the okay. So those are the conditions that won't allow the patient to take the sputum out from the mouth. So as this yeah, airways, you have to check for that. Auscultate the lung sounds. See, nothing but auscultation. That is the prime importance. You have to auscultate the lung sound. The lung sound should be clear. If there is any abnormalities in the lung sound, you have to uh, check that abnormalities. Okay, auscultation of the lung is the primary important thing. Then you have to monitor for the oxygen saturation. Okay, oxygen saturation should be assessed. Then assessment for increased amount of blood in the sputum. Hematemesis, hemoptysis, all these conditions mainly. What hemoptysis, hematemesis may not be associated directly with the respiratory system, but because it is having a direct connection with the GI system. But hemoptysis is having a direct connection with the respiratory system. What is the reason for blood in the sputum? You have to assess that. Then emphysema will be the then respiratory distress, which is shown by nasal flurry. Then grunting sounds will be the what are the labored breathing, your diaphragmatic breathing. All these things are the signs of respiratory distress. Then patency of the tracheal tube, whether all these things may happen if the tracheal tube is kinked or disintacted. So you have to check the tracheal tube also. Then postoperative pulmonary edema. I have to check that postoperative pulmonary edema also. So what I have said, the first thing is you have to prime treatment. What is the prime treatment? You have to stabilize the patient. Then you have to go for the antibiotics and airway saturation. Kindly note for the COPD patient, the usual saturation should be around 90 to 92, which is normal for them. It's not mandatory that they should maintain more than 95 or 96. Okay, 90 to 92 is the normal saturation. Then, in those conditions, in pulmonary edema, in case of lung abscess, there will be dyspnea, weight loss will be there, cough, sputum production, which will be presented with the blood, sleep disturbances will be the fatigue. The patient will easily go into fatigue, activity intolerance will be the patient will be lethargic. In some cases, since it is an abscess, there may be a chance of low grade fever. And fever may also accompanied by night sweats. Note that point. Fever associated with night sweats is a classical sign of lung abscess. Now, the airway obstruction. So we have seen the airway obstruction. See, I am not classifying all, I am not talking about each and every disease. I have classified the diseases so that it will be very easy for you to study. You don't have to study the 25, 30 diseases in respiratory system. Just understand on the basis of its classification. So that all the classification diseases will be having more or less same characteristics. So that you will be able to recall it when you are doing the prometric examination. So the airway obstructions. What are the airway obstructions? It will be life-threatening. It's a life-threatening condition. So foreign bodies can be a reason. Anaphylactic reactions, stenosis, lesions, swelling because mainly of anaphylactic reactions. Okay, there may be that is the main reason for the airway obstruction in adult. In children, foreign bodies are the main causes. So if there is a foreign body which is causing an airway obstruction, you can go for Heimlich maneuver if it is uh, possible both in adult as well as in children. Okay. And what are the causes of airway obstruction? There will be a viral or bacterial infections. Fire will be there. So I have said inhalation. Okay. When there is an inhalation problem, if we inhale carbon dioxide, it will lead to bronchospasm and there will be obstruction of the airway. Then that is inhalation burns. Okay. Then allergic reactions due to some foods, medications, bee stings, or anything which caused as an antigen to the body will lead to a reaction. And if the body is not tolerating it, or when the antigens amount is huge, it may lead to an anaphylactic reaction. Then an infection may be because of dental extraction. Then laryngeal trauma, strangulation. Strangulation means, what? It might be a suicide, hang yourself, or a person who is, it might be activity of murder, the strangulation. Then surgical procedures, any surgical procedures, as we have said, tracheostomy. Okay, it may lead to airway obstruction due to edema. Then large tumors, any tumors inside the lungs, large tumors, foreign body aspirations. Yeah. So we are talking about the airway obstruction, and the main cause of airway obstruction is your chronic obstructive pulmonary disease. Okay. Pneumonia may be also a reason for that. So what you have to check in this airway obstruction condition, mainly the COPD. Okay. Mainly in case of COPD, what you have to check in the this COPD condition. So dullness or dull abnormal findings are your when we are doing the percussive sounds, you will be hear a dull sound, which is an abnormal finding. Okay, and the resonant sound, I have said, when we are doing the percussion over an air-filled space. Yes, Rajeshwari, any doubt?
Sir, I'm having 9:30 duty, sir. Shall I leave, sir?
Kindly speak up. I'm not able to hear you.
Sir, I'm having
What? What?
duty, sir. Night
Rajeshwari,
duty.
I didn't hear you properly. Hello, Rajeshwari. I didn't hear you properly.
Sir,
Yeah.
sir, I'm having 9:30 duty, sir. Shall I
Okay,
leave,
you
sir?
can go. Yeah, sure, sure, sure. If possible, see, if possible, kindly attend the evening class, or otherwise, the recordings will be available in your app.
Yes, sir.
Okay, okay, leave.
Okay, sir. Thank you, sir.
So the resonance sound. Resonance sound is the next one, which is an abnormal sound. Okay. Sorry, resonance sound is a normal sound. So when we are percussing on an air filled area, it should be resonant. So if we are percussing the abdomen, should it be resonant? No, it should be dull, because it is not a space which is supposed to have an air inside that. So we have three percussive sounds: dull sound, resonant sound, and hyper resonant sound. So dull sound, which should be how you hear when we are percussing your abdomen. Okay. The resonant sound means it should be heard when there is an air-filled space underneath that. Okay. Third one is a hyper resonant sound. So hyper resonant sound is an see, a lot of air is present there under the area. That is a hyper resonant sound. So you can say the condition where the condition you have large amount of air in pneumothorax. Okay. In pneumothorax, you can hear a hyper resonant sound. So, simply we have explained it. Now, the ABG findings. Okay. ABG findings for acute respiratory failure. See, I said it is always related with the carbon dioxide. Okay. Hypoxemia. See, definitely there will be hypoxemia, but the hypoxemia status will be changing. But what you have to focus is on the carbon dioxide. Okay. The carbon dioxide, if it is more, what is the normal value? It is between 30 to 35. Okay. So in case of arterial blood gas, it is 30, and it is in the venous blood gas, it is 40 to 45. Okay. So 30 to 35 is the arterial blood gas. So when it is more than 450, it is hypercapnia. Okay. So just leave this. We have a no, this one, pulmonary embolism. That we the next condition is pulmonary embolism or infraction. See, what is pulmonary embolism? There is an emboli which is simply going through these pulmonary arteries or the pulmonary circulation. That is pulmonary embolism. Okay, so when this ventilation perfusion mismatch will be there. What are the main signs and symptoms? So the main signs and symptoms are there is a sudden onset of severe dyspnea. Okay, in case of pulmonary embolism, there will be a sudden onset of severe dyspnea. There will be restlessness. Kindly underline there will be a sharp pleuritic chest pain in case of pulmonary embolism. Okay. These things won't be you won't be able to find in other conditions. Sharp pleuritic chest pain in pulmonary embolism. The temperature will be increased. There will be a heart rate, a respiration, all will be increased. Violent cough will be there. Then there will be hemoptysis, blood in sputum. Diaphoresis will be there. What is diaphoresis? Diaphoresis is excessive perspiration. Excessive sweating is diaphoresis. Perspiration is normal, whereas diaphoresis is abnormal. Then what? How you can diagnose it? Pulmonary embolism. You can just take a spiral CT of chest. Okay, spiral CT have to take. You have to take a spiral CT. Then this ventilation perfusion scan. How it's the circulation going on. Then pulmonary angiography. Kindly write these down. Okay, pulmonary angiography. D-dimer assaying to understand whether there is a fibrin clot or not. D-dimer assay. You have to check the D-dimer assaying. And what is the management? Anticoagulant and thrombolytic therapies. Same how we do with the cardiovascular system. Okay, anticoagulants and thrombolytic therapies. And if possible, if the emboli is large, we'll do the embolectomy. Okay, these are the things which we are using. No, use of Tasco, don't need that. I'm not going to teach you practical things. Pulmonary edema, same. We have how we have explained it. Pulmonary tuberculosis, or the area which you have to focus is the medicine. What are the complications of the medicine? And the pulmonary tuberculosis, if it is, what are the main signs and symptoms? Simply there will be weight loss. Okay, cough for 2 days, 2 weeks, sorry, 2 week cough will be there. Lung abscess management, medical management, antibiotics. Now, capnography means carbon dioxide, measures inhaled carbon dioxide. That simply understand that. No further questions will be asked from the capnography. Pulmonary embolism, we have explained it. I think I have explained all these things. You know, there is a condition known as cystic fibrosis. Okay, so cystic fibrosis means what? Fibrotic changes will be there. Okay, fibrotic changes will be in the lungs, like lung abscess. So there will be fibrotic changes in the lungs. That is known as cystic fibrosis. Okay, now these are practical sessions. That's why I'm just skipping all these things. This endotracheal intubation and PEEP respiratory supports mechanical ventilator. We have explained it yesterday. That's why I'm just skipping all these things here. Uh, See, we have all things have been explained. Okay, I have explained all these things. Now the remaining some disease conditions are the we'll check on to these disease conditions one by one. Just a minute. So coming back to the conditions, next condition may be a pneumothorax. So what is a pneumothorax? It is just the collapse of your lungs due to disruption of negative pressure that exists in the intrapleural space. Kindly write it down. What is pneumothorax? It is a disturbance in its negative pressure. Okay, it's a collapse of lung. Pneumothorax means it's a collapse of lung due to disruption of negative pressure that is present in the intrapleural space. Okay, it's a collapse of the lungs with disruption of negative pressure in the intrapleural space. Okay, see, it also reduces the surface area of gaseous exchange and it may leads to the carbon dioxide retention and hypoxia. Now, we can see some types of pneumothorax. First condition is spontaneous pneumothorax. Okay, first condition is spontaneous pneumothorax. What happens in spontaneous pneumothorax? when there is a leakage in the lung ruptured area. What is leaking? The air is leaking, right? So that is known as spontaneous pneumothorax. When the lung area is ruptured and there is a leakage over there, that is spontaneous pneumothorax. It may be because of a stabbing wound into the lungs with a knife. It is a spontaneous pneumothorax. Next is traumatic pneumothorax. Traumatic pneumothorax means it is due to an invasive procedure. Like you can say thoracosynthesis. Thoracosynthesis may leads to traumatic pneumothorax. Okay, so now you know what is the main complication of pneumothorax. Infection is already there. These pneumothorax may happen in case of thoracosynthesis when we do the thoracosynthesis. Laceration wound. Hemothorax. What is hemothorax? Heme, blood in the thoracic cavity. It may, and again, it may be due to any stabbing, any traumatic conditions. Pneumothorax, hemothorax may happen. Next, fourth one is tension thorax. Kindly write it down. In tension thorax, there will be mediastinal shift. There will be a mediastinal shift in tension pneumothorax. Okay, there will be a tension. There will be a mediastinal shift in case of tension pneumothorax. Okay. Next condition is flail chest. FLAIL. Flail chest. Flail chest. It is the instability of chest wall due to rib fracture. Okay. Or because of detached sternum. Flail chest. Instability of the chest wall due to rib fracture or displaced sternum or detached sternum. I hope you are writing the notes. Next, what is the signs and symptoms of this pneumothorax? There will be unilateral pleuritic chest pain. Kindly underline it. It is a unilateral pleuritic chest pain. It is a unilateral pleuritic chest pain. Tachycardia will be the okay. BP will be decreased and the respiration will be shallow. Those are the main symptoms. Those are the main signs and symptoms. Okay. So next condition, malignant lung tumors. Malignant lung tumors or the lung tumors. Okay, lung tumors. What is TNM classification? T for tumor, N for lymph nodes, M for metastasis. That is TNM classification. Okay, so tumor means the amount of tumor. Lymph node, how many lymph nodes are involved? Metastasis means to which or organs it has been metastasized. Okay, so that is a classification. So it depends upon, for example, if it is a right lung cancer, so axillary lymph nodes will be involved. In some condition, if early we are identifying it, it will be just present in the lymph in the lung itself. So that is a tumor one, T1, which means it is there in the situ only one area, or if it is in multiple areas of the lungs, that is tumor is present in how many areas, that is T1, T2, T3, T4. If lymph nodes are involved, how many lymph nodes are involved? If metastasis, see the body has been divided like this. So lungs, whether it is crossing this middle line, if it is crossing the middle line, it is a complicated condition, or if it is crossing the adjacent line. Okay, so no need to understand. I am not going into deep into all these things. There is a TNM classification for the tumors. Okay. Now, what we need here in lung cancer is classification of malignant lung tumors classification. Okay. So first one is adenocarcinoma. Adenocarcinoma. Just understand the disease. That is more than enough. Adenocarcinoma. Okay. Second thing, squamous cell carcinoma, or it is otherwise known as epidermoid. Squamous cell carcinoma or epidermoid. Okay. Just understand the conditions. Then is small cell carcinoma. Small cell carcinoma. It is otherwise known as oat cell. OAT. Oat cell carcinoma. Okay. Next is large cell carcinoma. Large cell carcinoma. And it is otherwise known as undifferentiated carcinoma. It is otherwise known as undifferentiated carcinoma. Kishore, I am in the class. I'll call you later. Undifferentiated carcinoma or large cell carcinoma. Okay. Undifferentiated carcinoma or large cell carcinoma. These are the classification of the lung tumors. Okay. Adenocarcinoma, squamous cell, small cell, large cell. These are the classification of malignant lung tumors. Okay. Now, what are the main signs and symptoms? See, it is lung. So the main signs and symptoms will be persistent cough. Persistent, there will be always there will be cough. Persistent cough. Then chest pain. There will be chest pain. Right? There will be chest pain. Hoarseness of sound. Hoarseness of sound. Ashwati, why there is hoarseness of sound? Ashwati, why there is hoarseness of
Yes, sir.
sound? Why there is
Mm,
hoarseness of sound?
ഇത് പറയാം. Mm,
See, I have multiple times I have explained this. Why
okay.
hoarseness of sound is? One thing, you are not studying. Second thing, you are not listening in the class. Hoarseness of sound is due to unilateral laryngeal nerve compression. In this case, in tumors, there will be edema present over the areas which causes the what it will compress the vocal cord and it will compress the laryngeal nerve. That's why hoarseness of sound is there. Hemoptysis, blood in the sputum. Hemoptysis will be the weight loss. In case of TB, in case of cancer, you will have weight loss. Clubbing of fingers. Clubbing will be there because it will affect the um, capacity of hemoglobin to saturate it with the oxygen. Thus, desaturation. Always the patient will be having desaturation. That's why clubbing will be the X-ray finding. What is X-ray finding? That also I have explained. It is a coin-shaped lesion. Coin-shaped lesion will be the coin-shaped lesion. It can be seen in X-ray. How will you diagnose it? Simply a bronchial wash. Bronchial wash will help to identify the cell. Then biopsy, cytology of sputum, sputum cytology. So all these conditions will help to understand the malignant tumors. What are the surgery? What are the surgeries that we are doing? We can go for lobectomy. We can go for lobectomy. So the specific lobe, specific if it is affecting the lower lobe, we'll remove this lobe. That is lobectomy. Wedge resection. Wedge resection. That is the second surgery. Wedge resection. So small area. If it is in the small lower lobe, we won't remove the lobe, but we'll just remove that area. If it is affected in this area, we'll remove that. What is wedge resection? Next is pneumonectomy. What is pneumonectomy? Soumya, what is pneumonectomy? Pneumonectomy is removal of the lungs. We'll remove the lungs. Okay. Next cancer is CA larynx. CA larynx. Simply, if the laryngeal nerve is if the larynx is having cancer, we have to remove the larynx. When we remove the larynx, the laryngeal nerve will always be removed, so the patient will be able to talk. So the main nurse's responsibility is that you have to uh, the we have to focus on the communication status of the patient. So how will we communicate and all those things. So the majority condition, it will be squamous cell ulcer. Okay, squamous cell carcinoma. The CA larynx will be squamous cell. The vocal cord, the epiglottis, the laryngeal cartilage, all will be removed. So what are the main signs and symptoms? There will be sore throat. Sore throat. See, then all these disease conditions with the cancer, weakness will be the tiredness, fatigue, weight loss, lymph node, foul breath. Okay, foul breath. And what is the surgery? What is the surgery that you partial laryngectomy? Partial laryngectomy. In partial laryngectomy, one vocal cord and some parts of larynx is removed. So in partial laryngectomy, the patient can talk. Even with the hoarseness, he can communicate. That is partial laryngectomy. One vocal cord and some part of the larynx is removed. That is partial laryngectomy. Second is total laryngectomy. All larynx and all laryngeal portions will be removed, and we'll place a trachea for respiring. Okay. And the third surgery is radical neck resection. It's a modified removal of the larynx, radical neck resection. Then laser surgery. We'll go for the laser surgeries. And the last portion, what I want to suggest is carbon monoxide poisoning. So when we inhale the carbon, see the hemoglobin have one time affinity towards oxygen, 10 times affinity towards carbon dioxide, and 100 times more affinity towards carbon monoxide. So when there is uh, see near the hemoglobin, if there is one carbon dioxide, 1 carbon monoxide, 10 carbon dioxide, and 100 oxygen, this hemoglobin will go and bind with carbon monoxide. Okay, so that much affinity is the hemoglobin having towards the carbon monoxide. So it is easy to have a carbon monoxide poisoning. The main signs and symptoms of carbon monoxide poisoning is that if we inhale this carbon monoxide, you can have dizziness, confusion, palpitation, then weakness, a headache. Mainly there will be cyanosis. Cyanosis. And how will you identify that? There will be cherry pinged. It is cherry pink skin. Okay, it is a cherry pink skin in case of carbon monoxide poisoning. Cherry pink skin. Your level of consciousness also will be altered. You have to keep the patient in mechanical ventilator. So this is all about the respiratory systems. So thus we have completed the respiratory system. Guys, are you having any doubt?